Tonight, why a bone marrow transplant can mean life for someone, and learn how easily you can become a donor. The doctors are on call now.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
There's the valve.
All of them together.
And which was healthier, the yogurt and the bagel?
All right, I'm going to start by measuring the size of it.
You could also add grilled chicken to this recipe.
Blow hard! Blow, blow, blow! Keep pushing.
Let's try to position your head.
Pull red handle to open bag.
Every year, more than 10,000 people in the U.S. are diagnosed with life-threatening diseases such as leukemia, lymphoma, for which a stem cell transplant is the best or the only treatment. Although they're called stem cells, these cells aren't the same as the embryonic stem cells studied in therapeutic cloning and other types of research. The only way to get a stem cell for these people who need transplantation is with donated stem cells. This is where you, the viewing audience, come in. Donating blood or bone marrow is a voluntary process that starts with taking a swab from the lining of your mouth. Then you become a part of the worldwide registry, and if you ever match with someone in need of stem cells, then you have an opportunity to donate stem cells from your blood or bone marrow for transplantation. That's what the show is all about, learning about the illnesses that might need a bone marrow transplant, how the transplants make a difference in some people's lives, and finally how you can become a possible donor to help someone in great need. I'm pleased to have with me today Dr. Kelly McCaul of the Avera Cancer Institute. Kelly, thanks for joining me.
Thanks, Rick.
So what are you? You're an internist originally, and then you went on for training to be...
So I'm originally an internal medicine specialist. I then went on and did a 4-year hematology degree. And after that, my interest took me into more of the transplant end of hematology. So I actually did another several years in a leukemia and transplant fellowship before I was able to finish.
So I know you're Canadian, yeah?
Yes.
And you're all about doing the right thing. But where did you train?
I trained actually at several different universities through Canada. My hematology training and my internal medicine training was actually in Nova Scotia and Halifax, and then I did 3 years in a leukemia transplant fellowship in Vancouver, British Columbia.
Right. So different parts of the East and the West.
Correct.
And then you came to Sioux Falls, South Dakota. What brought you there?
Probably one word: need. I was actually recruited down to start a transplant program, and I came down and recognized that there was a tremendous need for this region for a transplant program. One of the big drawbacks for patients when they have to travel significant distances is that it's quite a tremendous burden upon both them and their family. And so I came down, started a program, tried to set up a regional program for not only Sioux Falls but the entire region. And so we provide transplant services for South Dakota, some patients from North Dakota, Iowa, Nebraska, Minnesota.
So transplant of bone marrow, but other kind of transplants.
So yeah, so transplantation for my world is really all about stem cell transplants, and that could either be bone marrow transplantation with bone marrow harvesting, or it could be peripheral blood stem cell transplants, which is harvesting from the peripheral blood.
Now, you and I talked earlier about harvesting, and I've heard worldwide that 25% of the harvesting for these stem cells is really from a bone marrow harvest, and the other is from a peripheral blood. They put it in, and then they spin it, and then they put it back in, and they go that spin for a period of time. What do we do here?
We do exclusively peripheral blood stem cell transplantation. We do not actually have a setup currently for bone marrow harvesting. We have found that we have not needed it, and so in the last 11 years that I've been here running this program, we've done several hundred, many hundreds of transplants, all of which have been peripheral blood stem cells.
So the people who donate here really don't even have to do anything but give blood, and it's not typically
Correct.
blood. It's sort of it's like giving blood, only it
Correct.
turns it around and gives it back to you after it spins off the white cells or the stem cells. How do they do that? I mean, what's this spinning thing?
So the technology behind this is actually called an apheresis machine, and what that does is it actually takes blood from someone's vein, and it runs it through a machine, basically in a centrifuge, where we're able to collect specifically the stem cells. We return everything else back to the patient or to the donor, and then we collect the stem cells.
Yeah.
And
so explain to me what a stem cell is. I mean, it's an early cell, right? It's multi-potential, right? It can do anything. It can turn into anything, right? I mean, is it sort of like the same blood that you get off of an embryo?
Yeah. So yeah, there are many types of stem cells, which is difficult for some people to kind of understand fully, but there are embryonic stem cells, there's blood stem cells, and there's multiple other kinds of stem cells. What we use is really just a blood stem cell, and that stem cell actually populates the cellular elements of our blood as well as our bone marrow, and then produces red blood cells, which carry oxygen, platelets, which prevent us from bleeding, and then white cells, which is our entire immune system.
Right, and explain the white cells. There are two major groups of white cells. One are the soldiers. They're basically just soldiers. They aren't generals. They're not even private first class. They're all privates. Those are the leukocytes, or the one side, not the lymphocytes, but the leukocytes. The lymphocytes are the captains and the majors and the planners and the controllers, right? Now, have I got that right?
It gets a little bit more complicated.
Okay.
The immune system is actually an extremely complicated organ system. Most people don't think of their blood or your bone marrow as an organ, but it's actually as vital as anything. You cannot survive without a healthy bone marrow, healthy blood system. The white blood cells that we have are very integrated between the two types, the neutrophils or other types of leukocytes and the lymphocytes, and they really actually are co-stimulatory and codependent upon one another to do their function. But they keep us healthy, they keep us happy, they keep infections at bay, and they allow us to actually function and survive.
Well, yeah, let's move to a story about Mary Bjerke, who I don't know if she's still the mayor of Volga, but she's a delightful lady, and she's involved with all sorts of community projects. But her story is interesting, so let's go to that.
I was a stem cell donor in 2009. About 10 years ago, we were visiting family in Kansas City, and there was a huge drive to get people signed up for bone marrow. And my brother and his wife encouraged my husband and I to sign up with them. And 8 years later, I received the call. It was from the National Marrow Donor Program telling me that I was a potential match for a 20-year-old female with acute leukemia. And would I be interested in donating? I received the phone call in July, and the donation was done on September 14th. So, and throughout that whole time, I'm communicating with the National Marrow Donor Program. I'm doing a lot of extensive testing with my blood work. I think I had 31 vials of blood taken throughout the whole procedure. The best part about the donation is that I'm working very closely with the Heart of McCaul at her through phone and walked me step by step through the process. The Heart of America's purpose is to work with the donor. That's their concern. They take care of me. There's other doctors taking care of the recipient, but I'm their only focus. So I felt really, it was a good sense of well-being, knowing that they were taking care of me. And of course, they cover all expenses. It's just my time is really all I'm giving, time and white cells. I really didn't experience any physical side effects. Emotionally, it was a challenge, and they had warned me that I might have some emotional problems. It's such a powerful 2 days of giving, and even though the physical didn't really affect me any, I was an emotional wreck for about a week.
So that lends the question, Kelly, are you a donor? Have you been swabbed?
Yes. I've been on the list actually for around 8 years.
Yeah, so have I. Actually, I'm off the list now because you can't be on the list if you're older than 60.
Okay.
But that doesn't mean that you can't do something for it. I mean, the people who feel like this is an important thing, they can also donate. So it's money. Money's a good thing. It takes something like $100 to process each swab. So it's probably worthwhile that people could understand if they cannot donate their swab, that it would be nice if they could, donate to the cause.
And we do donor drives on a regular basis to offset the cost as well. And sometimes it can be as low as free. Sometimes it's $40, $50.
We have a question about is there a future for using stem cells for other illnesses? What are the, for example, cerebral palsy or other conditions? What are the major reasons that we do bone marrow transplants for now?
The predominant indications for a bone marrow or stem cell transplant is going to be one of the blood-related cancers. And the vast majority of patients that receive a transplant, the indication will be for lymphoma, leukemia, multiple myeloma, myelodysplastic syndromes, or other bone marrow problems that require that they receive a transplant.
There's such a change. I mean, there's this huge change in being able to treat those conditions you just listed, because when I started, there was no treatment. I mean, we had chemo, but it was a matter of giving them some time, but it wasn't a cure. Now we have cures. What are the cure rates? I suppose it depends upon the illness.
It very much depends upon the illness, and it also depends upon the patient, their disease stage, so what type of disease they have, but also where it is, how aggressive that disease is, and so really there's
no answer to that. It all depends.
There's 100 variables that come into every single patient, and that's why we basically have individualized therapy based upon the patient and then what we require to get them through for curative intent or long-term control. To make it better.
Correct. So what about things such as cerebral palsy? That's a can of worms.
There are a number of indications that are in the experimental mode for blood stem cells in terms of transplantation. And one of the most exciting ones, I think, has been certainly ischemic heart disease. So people that have a myocardial infarct, there's a lot of work that's been done over the last decade or so. In fact, there's some really good Canadian work that's been done up in Montreal, actually, that has pioneered some of the new approaches. The indications are probably limitless. A lot of it is actually just in the experimental phase right now. but cerebral palsy would be one, Parkinson's, rheumatoid arthritis, various Crohn's disease, lupus. These are all diseases that can be potentially amenable to a transplant in the future.
Well, I mean, I can see Crohn's disease or some of these that are very rheumatoid arthritis. Now, they're immune system diseases. I mean, there is something gone awry with probably their controller white cells,
Correct.
right?
Correct.
It's a disease of the bone marrow,
Correct.
not of the joints or not of the colon. And so doing a bone marrow transplant, giving somebody a bone marrow that doesn't have rheumatoid arthritis or doesn't have Crohn's disease, it makes sense. Ischemic heart disease, explain that to me.
Yeah, so the ischemic heart disease issue is really to actually get viable tissue to regrow. Traditionally, we look at a myocardial infarct or a heart attack as having tissue that is dead. We have now, early literature that would certainly support that infusion of stem cells, blood stem cells, down into the coronary vasculature could actually revive and regenerate new heart muscle.
Wow.
And the same could hold true potentially for patients with strokes, Parkinson's disease, and we've even looked at other things like cord transections, like paraplegics and patients that have been through car accidents that have a damaged spinal cord.
People who are paralyzed from the spinal cord, the idea that a stem cell could be used to regrow that spinal cord.
Correct, because you can take the blood stem cell and you can drive it down a particular pathway to produce a different type of tissue. So it doesn't have to just be red blood cells, white cells, or platelets. It could potentially be cardiac muscle cells. It could be the spinal cord. It could be brain tissue, all of which are, again, experimental, but very exciting for a potential future.
Now, Mary Bjerke talked about the fact that she felt drained after her bone marrow donation. Can you explain that?
When patients go through a donation of stem cells, we actually require to give them a drug called Neupogen or GCSF, which actually stimulates the bone marrow. It then actually releases the stem cells from the marrow into the blood so we can harvest them. That process actually takes around a week, roughly about a week, and the collection itself is also a little bit tiring. Patients have to be hooked up to an apheresis machine for somewhere between 4 to 6 hours to collect their stem cells, and so fatigue is really quite a common manifestation from a donor. But overall, it's really actually quite simple, and the donors are often very happy to be able to do that.
I mean, a little fatigue. I take a little fatigue. And you have a new life. Hello. It's worth a little bit, and that the fatigue lasts maybe a week or
not even. Usually, it's after within 24 hours or so after they've finished collecting, the fatigue and sometimes the bone aching would be completely gone.
Now, a question I have is you talked about a medication to give to a person prior to the transplant. That's a bone marrow stimulator. I know we use it for people who have anemia because they are on kidney transplant or kidney dialysis. People who have dialysis and their kidneys are not driving their bone marrow to make red cells. I mean, isn't that interesting that our kidneys drive our bone marrow to make red cells? So if our kidneys quit, we get anemic. But now we push our bone marrow to make red cells when they have kidney failure. In the same way we have other bone marrow pushers. Yes. And you just talked about giving them before the donation, right?
Correct. So there are numerous little chemicals that we call cytokines. And these cytokines are actually now cloned basically through the lab technique. And so there's several that we actually use on a regular basis. And they're erythropoietin, Neupogen or GCSF, and then there's also different ones for other cells as well.
Platelet stimulators.
Platelet stimulators.
They're aimed right at the platelets or aimed right at that white cells.
Yeah, the technology has really become quite interesting.
Before we take a break to the next story, I was wondering about people who have things such as infectious illnesses that are involving the bone marrow, AIDS. How about a bone marrow transplant for a person with AIDS?
I think that there are some reports of that. Usually, at least in my experience and here in the state, we've used stem cell transplantation for patients that have had HIV or AIDS, but mostly in keeping with a cancer that they've developed as a result of that illness. So they develop a lymphoma,
right.
And then they require a transplant.
And you give them the transplant. How does the HIV or AIDS go away?
No, it can actually become more quiescent and
quieter.
And the patients that we've actually taken care of in this state through our program in the last 11 years, because obviously I know all of them, they've done very well.
Yeah, that's interesting. Well, there are medications that we should talk about, and we interviewed a specialist in the medications for bone marrow and for stem cell transplant. Let's hear that.
There are a variety of different drugs that we can give to patients to help prevent rejection after they've had their stem cell transplant. A majority of the medications we use are ones that patients can take orally at home. Those would be drugs like Prograf or Cellcept. They can take prednisone to help with that. And then we can also do some IV medications here in the clinic, one being methotrexate that they would get as a short infusion on specific days to help prevent that. The medications that we use oftentimes depend on what type of a transplant patients have. If they receive their own cells as a part of the transplant, or if they've had cells from a donor. So if they've had cells from a donor, we're more concerned about issues with rejection or like graft versus host disease. So those patients are the ones who would get the drugs to suppress their immune system. All of our patients, because their immune systems are suppressed, are vulnerable and more susceptible to other infections. So a part of their medication regimens often include antibiotics or antivirals, antifungals to help prevent them from getting other illnesses on top of their recovery from transplant. For the immunosuppressives, they're usually on them for about 100 days, and we'll try and taper back on the doses that they get. If they would start to show symptoms that they're developing graft versus host disease, which is what we look for, then they may need to be on medications longer. After transplant, your immune system is essentially back to the point that it was when you were an infant. We revaccinate for like hepatitis or the different influenza, for polio vaccines. There's the whole schedule of things that you would get as a child. They're essentially getting re-administered after transplant. We have schedules where at certain points out after transplant, we kind of flag patients' charts so we know, at this point a patient's due for vaccines ABC. I think the important thing is just knowing that after patients do have a stem cell transplant, it doesn't just fix everything, and there are still prolonged concerns that we have to watch for until their immune system can build up to the point where it can function at an adequate level to keep them healthy as well. It's not just a one and done process. There's definite time involved.
That's so interesting. I was just thinking how once you've had wipeout of your own bone marrow that had this lymphoma or leukemia, and you get a new bone marrow, they have to revaccinate you and reestablish your immune system. Isn't that amazing?
Yeah.
I mean, you start from stem cells, so they didn't have any memory.
Yeah, and there are sometimes people will have some residual immunity, but in general we tend to just vaccinate across the board for all the typical childhood illnesses, like measles and mumps and rubella and diphtheria.
Yeah. Now, curveball. our country is going through a hard time. You know, right now trying to decide how we're going to control the cost of health care. And it looks like we are twice as expensive as the next most expensive country. And yet we have equal or less quality of health care by some measurements, mortality, morbidity, some measurements. Some could argue the measurements aren't good, but still. And you come from Canada, who has a health care system where everybody has health care. Everybody has it.
Correct.
And the cost is half of what it is in the U.S. It's breaking the backs of our government as well as our employers. What's your comment about that? I mean, bone marrow and stem cell transplant is a very expensive therapy. Are we doing it too much? Could it be cheaper? What about what they're doing in Canada? I'm going to throw that barrage of questions at you.
It's definitely a curveball, but
yeah, it was,
but that's
it?
okay. I think that the difficult thing is that you take somebody, say at the age of 20, and they have acute leukemia, and if it costs, say, a couple $100,000 to take them through transplant and cure them, if you look at the rest of their life, where they're off of all their drugs, they don't take any immunosuppressing agents, hopefully.
Yeah.
They're cured and they live a normal, natural, healthy life. I guess if you look at the production that individual puts back into society,
it's way worth it.
It's way worth it. So, and if you ask the individual, they will guarantee
it was worth it.
It was definitely worth it.
Yeah. Well, what about? But is there a time that we're giving? Let's say we have somebody with myeloproliferative disease at 90, or 85, well, or 80, well, or 75. Well, now we're getting too close to my age. I mean, where is the cutoff where our society, where is that gain? And where is there a time that we're going to be limiting the ability to do a stem cell transplant?
I think that if you were to look at the different healthcare setups across the world, Britain, Canada, New Zealand, and go through them, almost all of the healthcare systems that are out there do actually limit. I think that that's going to be the major challenge for the United States, is to try to limit in terms of cost. I think it gets very difficult when you start to limit when you're talking about an individual. And there is certainly, I think, a way that has to be approached. Exactly what that's going to be, I'm not sure.
It's tough.
It's very hard.
You were there in Canada watching that ration and going on.
We saw some rationing for sure in Canada. A lot of it came down to delays in getting certain tests or procedures. In general, though, when I was in Canada, most of the training that I did, if you needed health care, you would get it very quickly. If, for example, you came to me in Vancouver and you needed a transplant, we would take you through. It would cost you nothing, and we wouldn't even look back.
All right. What about, let's switch to another issue. What about using your own cells for transplant? There are people who have a donor transplant, and then it was mentioned about using your own cells.
So there are many types of transplants in terms of bone marrow stem cell transplantation, and you can use your own, and that is actually what we call an autologous transplant. An autologous transplant is used in certain disorders. For example, patients that have Hodgkin's disease or multiple myeloma, where we treat the individual, we take care of their cancer, we collect their stem cells, we then freeze their stem cells and put them into a special freezer at minus 140 degrees Celsius, and we preserve them and protect them. We then actually treat the patient again with a higher dose of chemotherapy to try to actually wipe out any residual cancer, and then reinfuse back the stem cells to support them.
Hopefully without any of those bad cells in them.
Hopefully without any bad cells, but certainly the statistics and the numbers are very much in favor of that type of process.
Wow, so getting your own cells, and then you don't end up having to take immune system, anti-rejection drugs.
Correct.
Do you need to do a lot of anti-rejection meds? I know if I get a kidney transplant, I need to be on, I've got somebody else's kidney, and my body is going to say, this is not my kidney, this is an invader, and it's going to try to throw it out. Does that happen with bone marrows?
Well, when patients have a donor type of transplant, what we call an allogeneic transplant, they do require anti-rejection type of meds. We don't really call it rejection. Actually, what we call it is graft versus host disease. Right. So the new immune system that you can from a donor will actually see the individual as being foreign and will attack them.
So the graft, the donation cells say, oh, yep, the human being that I'm in now, that's
not me.
That's not me. We've got to kick it out.
Correct.
And so that's graft versus host, not host
versus graft, which is technically what rejection is when somebody rejects a kidney or a liver.
But you see more graft versus host.
We see predominantly graft versus host disease because what we do with our conditioning chemotherapy and our transplant is that we actually wipe out any residual immune system reactivity from the donor or from the patient.
From the host.
From the host. So we wipe the host, we transplant in a new immune system.
Wow.
And that,
how do you handle it then?
Well, we handle it by having very, very specific protocols that we actually take care of them and specific drugs that we have that we use. Right. And the major reason for using an allogeneic or donor type of transplant is actually because that new immune system can see the cancer as being foreign and will attack the cancer.
Oh no, I hadn't thought of that.
And will cure them.
So you have a new immune system that says cancer's bad, and the host immune system was failing.
Correct.
So you got a new immune system to go after the cancer.
Correct. And we call that the graft versus a leukemia or lymphoma or tumor. And that is very well established now for many years and is the predominant feature of cure.
Wow. Let me ask you one other comment. So let's say that I swab you. Well, you've been swabbed. You've been swabbed for 8 years and they haven't called you. How often does a person who gives of their saliva, you know, they get on the registry, how often are they used?
Well, it's kind of a statistical formula that comes into that. It really just depends upon your DNA as to whether or not you will match actually with a patient that needs it. And that will therefore be really the major piece. And there's around 6.5 million donors in the North American donor registry. And I keep waiting to get called, but haven't been called yet.
Well, the guy that looks just like you inside hasn't gotten leukemia yet. There you have.
That's a good thing.
It's a good thing. Well, let's continue with Mary Bjerke's story.
For me, it was just a real great honor to actually be a potential match, and to think that I have the potential to save someone's life was just beyond measure. Probably one of the most extraordinary things I've ever experienced. And it really is a gift. I've learned that it's a gift that I was able to give. I'd do it again and again. And I would encourage anybody to consider doing it. And this is from my recipient, and this was like gold coming in the mail for me. I want to thank you so much for giving me a new life. You are the person who made it possible that I can celebrate my second birth. There's no greater present. It's my greatest wish to visit you sometime to express my deep gratitude. I will keep you in my heart all my life, and I'm really looking forward to the moment of our first appointment. I wish you all the best. So we're just waiting to put a time together so that we can meet.
Wow, you could see the tear in her eye on that story. Let me ask you, I think about as a job as a physician, that I break my heart periodically, you know, over the patients that I care for, and there's a death that happens. There was a death today for my family, you know, my patient's family. And it's kind of hard to, how close can you get to the next one then? How do you feel about that?
I think that it's always a little bit more difficult to become close to your patients, but I think it's also much more rewarding in the end. We do suffer from compassion fatigue, where we see patients that we know quite well and they die, sometimes really not very pleasant deaths with cancer that is progressive. But in the end, we're really there to take care of people and try to cure them, and hopefully we can get them through with dignity and respect.
See, that's the, of course, the big deal is, or the thought is, that the oncologists and the cancer specialists don't know when to quit sometimes. I have even made that criticism myself. Not about you, but other
good,
but other oncologists. And my question would be, what's your response to that? Do you sense that people sometimes think that that's happening with you? That and have you thought, well, I shouldn't have done that?
That's a very difficult process, because when you take someone through with a difficult disease and a disease that will kill them, to stop is an awfully final pathway. For someone to die is the final pathway. And so we like to try to exhaust what options we can. I think the way that I usually try to approach this is really actually doing exactly what we're doing. We have a conversation. We sit, we talk about options, and we do it with as much knowledge. I try to impact as much as I can with regards to their decision making, so that they make a good decision based upon knowledge and the facts that we have.
Oh. What about your sense of spirituality? I mean, maybe it's unfair to ask you this. I live with people facing death all the time. It has truly made me think about my own. And I lost my sister when she was 19. So I have a philosophy that's it's very much affected by the world I live in.
Yeah.
All right, how do you think about it?
Yeah, it's always very difficult, because we see people that go through this process every day.
Yeah.
And on a regular basis, we have patients that are dying, because we do deal with very bad diseases, and not everybody is cured. Not everybody we can get through. I try to just be very grounded and try to be very empathic, and really just look after them and do the best I can.
And then you sleep well at night. And then you sleep well at night.
I have a very important rule of thumb, and I'm sure you have it as well as a physician, that if you do the best that you can do at every single step, then you can go home and you can sleep.
Yep.
Because otherwise you will not sleep.
I do not sleep if that. I mean, that's it. You just do as well as you can. That's really true. I want to make a point that in Brookings, where my wife, you'll see Joni in a minute, is running a Marrow registry at the Methodist Church on this Saturday, at 8 o'clock in the morning to 1 o'clock at the Methodist Community Life Center, across from the video store. So, on Brookings, if we're doing a push for people to come in and get free pancakes and swab their mouths, do the swabs and then the pancakes.
That's probably the best way to do it.
And so I think that's worth thinking about and talking about. So, good. There's a question from Sioux Falls. A patient had surgery on her knee, and the doctor mentioned stem cells. Is it possible to take stem cells from a synovial fluid, or switch them, or give them to the knee? Do you see any orthopedic or back pain or chronic bone pain solution with stem cells?
I think that kind of ties into some of our earlier comments about looking at myocardial infarcts, or either dead or damaged tissue at any point in the body. And knees would certainly be one area that potentially could be amenable to stem cell therapy from a blood stem cell in the future. Again, there's a lot of different investigational work that's being done out there.
Okay. So let's talk a little bit more about donating. If you donate your genetics into this master source, can they use that information against you? Let's say they're looking for the murderer of blah, blah, blah. Is that ever accessible to the police? Do you know that? I mean, that's a funny question, and I know that that...
Yeah. I don't think that it's actually accessible. I think that it's pretty much in the purview of the National Marrow Donor Program, and basically when they take the swab, they just run your DNA and it comes out in a sequence of letters and numbers. That sequence is put into the DNA pool in the computer. No one can really access that outside of the National Marrow Donor Program, or I mean, I search donor programs in other countries on a regular basis to pull donors for patients that we have.
So, and we're getting donations for leukemia patients and so on from all over the world. Is that right?
Correct. We've transplanted patients from many countries in Europe, Germany, France, Belgium. We've looked at donors from Canada, through Brazil, through really almost all the countries in the world actually now participate on some level with a donor type of registry.
And if I registered, and they found out they're not hunting for other diseases, so they're not going to call my insurance company and tell them that, oh, by the way, I have an Alzheimer's disease gene, and that I'm going to die early of Alzheimer's disease. Don't insure this guy.
No.
And what about if I donate and there is a possibility of a meeting of the person who receives my bone marrow? Is that possible? Does that happen?
It happens, very much it happens, because typically the individual that makes the donation of their stem cells, there is a requisite time period that the patient and the donor have to have no contact, and the registries actually make sure that there's very little information. Even from my perspective as the physician that is using these stem cells from another individual, an unrelated donor, we are unable to talk about age, sex, where they live, anything. It's got to be very, very separated. But at some point, if the patient's doing well and chooses, they can actually contact the donor, and then they can become involved with one another.
What about cross-racial donation? Could it be that if I got leukemia and I needed a stem cell donation, would it ever be a Chinese or an Indian or a black person that would be donating? Does that happen? Or do they pretty much stay in the same racial plane?
No, we've actually had a patient here in the state, it was around 6 years ago, that was Caucasian. The best donor that we could find in the world was actually African, and we used their stem cells for transplant purposes. So it very much can occur. Typically, however, Caucasians tend to have a more similar DNA pattern than other racial groups. And in fact, the racial groups as we kind of know them are really actually, we're all human. It's just skin tone, it's just surface stuff. And so most of it actually comes down to just our DNA pattern.
So you mean that even though you're really a white guy with red hair and I'm a real dark complected white guy, but you know, we look a lot different, but maybe we're pretty close?
We're very close.
Yeah, actually. Genetically we really are.
Genetically, actually, everybody is very close. Everybody across the world.
Yeah, amazing. So the other thing that I wanted to ask, so I swab my mouth and I am now on the donor list, and it comes down maybe 2 years later and they say, hey, would you like to donate? Can I say, I've changed my mind?
People can always back out. I think that if people know that they're going to back out, we'd prefer that they do it before we actually kind of call them up, because it's a little bit more difficult, particularly for the patient. It's a very emotional time, and I've had that happen before. But people as a donor can always back out, and in fact, we can also always screen that donor out if they've had any issues. So if, for example, somebody has developed Crohn's disease or rheumatoid arthritis after they've been a donor or after they've been on the donor registry, we would probably actually screen them out on our end.
Right, and you need to keep up with that donor list if you come down with some kind of disease like that.
Correct.
Well, why do they cut off at 60? I kind of feel like I'd be a good donor, but my cells are old. Is that what you're telling me?
The risk of graft versus host disease, so the new immune system attacking the individual becomes greater with age. And I don't want to say anybody's age, but it does come into the equation. And so we typically would look actually at the best donor, which is usually the youngest male donor that's never been transfused and is otherwise completely healthy.
So, and male because?
Male because females tend to have babies and men don't, as you know, and that having babies actually exposes them to a different individual, and there's always some placental transfer of red blood cells, which then stimulate the new immune system, which then also increases the risk of graft versus host disease.
So finally, there's something guys are better at than girls.
It took us a long time.
Well, we have one more story I'd like to share with you.
If you register to be a bone marrow donor, you have the potential for saving someone's life. It's a simple process of taking some cells on a swab from the inside of someone's mouth. Those cells are processed and the information is put on a national registry. From that national registry, if you match someone with a blood disease, a blood cancer usually, your cells could be put into that patient and restore their health. It doesn't always work. The patients know that when they go into it. If the people that need the donation, they know that there's a chance that they won't survive it. But if they have used up their options many times with chemotherapy, or if the physician feels that this is the best option for them, it could certainly be life-saving. About 75% of the time, depending on the kind of blood disorder and the physician's treatment, that they'll ask you for blood cells. About 25% of the time, they'll ask you for a donation from usually your hip. As many people that fit the guideline and that 18 to 16-year-old would be encouraged to donate. Particularly younger people are encouraged because they're on the list for a longer period of time. And we especially are looking for people with diverse backgrounds. Your blood type, your cell type is determined by your ethnicity. So if we have a patient in need who has a mixed background, they're going to have a more difficult time finding a match. So we are particularly looking for donors who may be of Hispanic, American Indian, or a mixed background, mixed racial background, because their cells may be just what's needed to save someone's life. On Saturday, October 1st, there's an event, a pancake breakfast that's open to the public at the First United Methodist Church Community Life Center. Anyone can come, have pancakes, and if you meet the guidelines to be a donor, we can do a simple oral swab that will get you on the list to be a potential donor if you ever match someone. If people want to come to the pancake breakfast on Saturday, October 1st, we'd be happy to have them even if they are not able to donate cells. It would be great if they could make a cash donation because it does help with the whole process. BeTheMatch.org is a great website that will give all kinds of information to people who may not be able to make it to the event on October 1st, or if you're in another community and you'd like to have your own bone marrow registry drive. All the information is at Be The Match. They have very helpful staff that will get all of the data to you. They'll educate you and get you on the road to having your own bone marrow registry event.
Now, wasn't that a lovely lady? Thank you, Joni. That's my partner and my life partner, the mother of our 4 children, and another project that she's taking on, and it's a wonderful project. And I might want to point out that there is a pancake breakfast this Saturday morning from 8 o'clock through 1 o'clock. We want you to come down to the First United Methodist Church Community Life Center. It's the building right across from the video store on 6th Street, and pull in there and swab your mouth or donate $1 or $2, and give to this particular cause. So thank you for promoting that, Joni, and for getting that going. And think about it, people. A free pancake breakfast would be a good thing. And you promote this. You have drives like this as well in Sioux Falls?
Yes.
And anything that we can, does it seem to happen every year, or do you have a...
We run donor drives typically once a year, once every other year, or a couple times a year. Just depends upon our staffing at the time and what is actually currently happening through the community.
Okay. Well, with that, here comes this essay that yours truly wrote this week, and let's hear what this character has to say. There's a famous old Jimmy Stewart movie that comes up every Christmas, which tells a story about how the little things that a person does for another impacts many people in powerful ways. The movie always makes me think of the long-term consequences of saving a life. Every day, each of us have opportunities to affect others in positive ways. Maybe one day it might even be to rush into a burning car and rescue a desperate crash victim. But more likely it would be to provide simple acts of kindness to people in need. In the medical business, you don't have to go very far to find people in need. Recently, cancer of the lymph system was diagnosed in one of my patients, which had already spread throughout her whole body to include the blood-making cells of the bone marrow. Treatment included chemotherapy that wiped out all the lymphoma, including her bone marrow. And then new bone marrow cells were provided, donated by a stranger in some distant place. The new cells, like planted seed, began to grow, and in a few weeks returned her to a disease-free life. Just think of the long-term consequences of the gift of that new bone marrow. In the U.S., on any given day, there are about 6,000 people who similarly need such a bone marrow transplant. But from where do the transplants come? Well, they're from family and friends and volunteers like you. To register or donate to the National Bone Marrow Registry, just search the internet for Be the Match, and you will be taking the first step to rescue a person in need. If you qualify, you will be asked for a mouth swab test, and if you match, the procedure to donate is a minor inconvenience and would cause minimal discomfort. This is one example where science, along with volunteers like you, has been able to prevent tragic and early deaths. It's a simple act of kindness. You don't have to rush into a burning car to save a life. Well, he's a really emotional guy, wouldn't you say, Kelly? I think the important point is that there's some places that you could donate to. If you're out all alone in the country, you have no connection, no community, here are some sites in which to go. BeTheMatch.com, you could internet them, call that number for Heart of America Bone Marrow Donor Registry, and they'll send you a kit. You can swab yourself and mail it back. You don't have to come even to get the free pancakes to do this kind of a thing. I like to say the other thing, Kelly, is to encourage communities to do these kinds of things. What is your comment about that?
I think it's actually very important to become a donor. The impact for someone else is obviously quite large. We have many patients that we will actually look for an unrelated donor across the world and never find a donor.
It happens.
It happens. Sadly, it happens.
More often than we want to even.
And even right now, we have patients that are being treated that have a very poor donor history across the world, and we've taken the best donor that we can take. But obviously, potentially someone that lives right around the corner could be the perfect match.
So if you want to start a issue like that, call those sites that were on the line there, or go to our internet site, On Call, Google On Call South Dakota, and look at it. Kelly, I know this was a donation from you to come up here, give your time and expertise, and share a little bit about your heart and soul. Thank you very much. Appreciate you doing this.
Thanks, Rick.
And stay healthy out there, people.
Funding for this program is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Television.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding provided by Dakota Care, the Brookings Health System, Regional Health, the South Dakota American College of Physicians, and Swiftel Communications. Closed captioning for On Call is provided by the generous support of Avera, the Brookings Health System, and Fishback Financial Corporation.
To learn more about life and health, you can order your copy of The Picture of Health, a beautiful book containing insightful essays and evocative images by on-call medical editor Dr. Rick Holm and Dr. Judith Peterson. This book, containing healthcare advice, stories of medical history, and meditations on healing, can now be yours for $17 at the South Dakota Ag Heritage Museum. Call 1-877-227-0015 to order.